Welcome to the Read, Talk, Grow podcast, where we explore women's health topics through books. In the same way that books can transport us to a different time, place, or culture, Read, Talk, Grow demonstrates how books can also give a new appreciation for health experiences and provide a platform from which women's health can be discussed. At Read, Talk, Grow, we use books to learn about health conditions in the hopes that we can all lead happier, healthier lives. I'm your host, Dr. Denise Millstine. I'm an assistant professor of medicine at Mayo Clinic in Arizona, where I practice women's health, internal medicine, and integrative medicine. I am always reading and I love discussing books with my patients, my professional colleagues, and now with you.
So excited about my guests and about the books we'll be discussing today. My first guest is Heather Corinna, who is the author of What Fresh Hell Is This? Perimenopause, Menopause, Other Indignities and You, as well as the author of SEX, the All You Need to Know Sexuality Guide to Get You Through Your Teens and 20s, and the co-author of Wait What? A comic book guide to bodies, relationships, and growing up. Heather's also the founder and director of Scarleteen, the pioneering inclusive sexuality, relationships, and health education resource for young people, which was established in 1998. And they are currently the sexuality chair at Our Bodies, Ourselves Today. They're based in Chicago and have been working as an educator, advocate, and writer for over 30 years. Heather, welcome to the show.
Thanks for having me here.
My second guest is Dr. Jewel Kling, who's a professor of medicine and chair of the Division of Women's Health Internal Medicine at the Mayo Clinic in Arizona. She's the assistant director of the Women's Health Center for Mayo Clinic and the associate chair of Equity, Inclusion, and Diversity for the Department of Medicine at Mayo Clinic in Scottsdale. She completed medical school and a master's in public health at the University of Arizona, Tucson, an internal medicine residency and chief residency at Mayo Clinic in Arizona. Her clinical and research interests are in menopause, sexual health, and LGBT care. She's a North American Menopause Society certified menopause practitioner on the International Society for the Study of Women's Sexual Health and the American Medical Women's Association Sex and Gender Health Collaborative. Dr. Kling, welcome to the show.
It's such a pleasure. I'm so excited to be here.
Well, Heather, Jewel and I have talked about your book back and forth and have both recommended it to several patients. So the book we're mostly focused on today is What Fresh Hell Is This? Which is so incredible. You know, the cover, who were you thinking about when you started with this cover?
You know, they get a designer to do the cover, but we did give them ideas and pretty much it was nothing but flames. I mean, I wrote the book both during pandemic and during like the very worst part of my perimenopause. So I don't know. I think everything in my brain was surrounded by flames, but yeah, they did an amazing job. I love the cover.
Well, I have a story for you that I think you'll appreciate. So a few years ago, I was frustrated because like my periods were abnormal, they were changing. I work in women's health. And my office mate came in and said, well, you're perimenopausal. I was like, oh, bite your tongue. Because of course, I think I'm much younger than I am. But you are also an educator in this field. And as you were going through perimenopause, you too had the experience. What is going on? It felt like a huge mystery.
You know, it's one of those things where the more you find out, the more you find out you didn't know, and I really didn't know Jack. And, that's after over 20 years of working very solidly in sexual and reproductive health and education, around human beings of various life stages, right? All things that you'd think you would know, if not a lot, the basics. But I mean, I feel like even the things that I thought were so basic, I was so often completely wrong about.
And Jewel, just like Heather, you realized there were huge gaps in knowledge around perimenopause, the menopause transition, which now you're a menopause expert and have focused your career on that. Tell us about how you made that decision.
Well, I was going to say to Heather's comment, and Heather, thank you for this book. Beyond it being great, it's just honest and personal. And for you to share your experience of going through perimenopause to help other people is just such a gift. But as you spoke about, being in this field, being somebody that maybe should know this information and not knowing and then going through it, I think what has surprised me is how little the medical practitioners that we expect that should know this information don't know. And so I can even see people turning to your book to get that information because they might not get that accurately from their physician or their advanced practitioner. And that's not a fault of theirs. I mean, we could talk about the history or the contributors, and there's many that have factored into the fact that we really need to do a better job of educating professionals so that they can help women and people navigate their journey through perimenopause and menopause.
Yeah, I mean, I think one of the things is that the lack of knowledge about this is really, it's so universal. I mean, it's like you can be whatever kind of expert that you want to be. But yeah, I think that's the other thing. People will kind of say, why didn't my doctor tell me about this? Why didn't my mother tell me about this? And not only are everyone's experiences with this who actually have them for themselves so divergent, but I mean, we're all, by and large, as a culture, missing so much information.
I love how you start just at the very beginning of the book with simple definitions about perimenopause, the menopause transition. I'm about to give a talk later this afternoon to medical professionals, and I'm going to use the same definitions because people make mistakes about them all the time. Premenopause is when you start having your period while you can have babies until you become perimenopausal. And yet people will, come and say, I think I'm premenopausal, and they're, in their 30s. Obviously, they've been premenopausal for 20 plus years. Right. So it's a mystery to a lot of people.
Well, and even coming up with how to explain that for something that takes up relatively small amounts of space, that's the stuff that matters. And when you're thinking about it, particularly, you have to think about it in a way where, and we, the same thing happens teaching sex ed, right? Where it's actually factual and accurate to the best of our knowledge at this time. All this stuff, as with sexual health, 10 years from now, I'm sure that we'll have to make changes because we'll actually know things that change our understanding of how this all works. But then also it has to be accessible. Everybody needs to be able to use it. A lot of people don't like the term menopause, which is understandable. But then you also have to ask yourself a question of, especially when someone goes to a healthcare provider, if everybody doesn't have somewhere where we can meet and speak the same language, it makes it even a million times harder to try and get the care that you need and the information that you need, and for everybody to be on the same page. So yeah, I mean, that stuff is really tricky. And I feel like even with that, we always want to be reevaluating to be like, does this still work? Does this work for us? Okay.
What I really learned and liked how you did those presentations, they were evidence-based, factual, it makes sense in the clinic how we communicate, but also patient-centric. I learned something reading your book about how we approach or call things like normal or natural menopause and how that leaves people out by just using those terms. And so there's other ways that we could converse about menopause that's more inclusive and engages with people, so it's more inviting. Then we can navigate that journey with them together.
Well, you talk a lot about all the different symptoms that come with perimenopause and talk about journaling and tracking those symptoms because they can be caused by other things. They can be confusing. You don't know you're in menopause until 12 months after you stop having your period. So there's this long time period of perimenopause where you're experiencing symptoms. Dr. Kling, you've been working on some projects to help women track their symptoms a little more consistently. Can you tell us a little bit about that?
Yeah, there's twofold. The goal of our research here in women's health is both to answer more questions, because just like the information about perimenopause and menopause has little infiltrated medical training and even pop culture, when we look at the research, there's so much that needs to be done, particularly as it relates to people that identify with other genders apart from cisgender people. But even for just cisgender women, there's such a lack of data particularly for people of marginalized groups and populations. So our research efforts are twofold. It's really to explore some of those outcomes, associations. So looking to see how do things like adverse childhood experiences impact the menopause experience? If we could, how does somebody's skin color impact the bioavailability of the hormone therapy that they use if we're recommending it transdermally? So we'd love to answer those questions, but then also use those and directly translate them in our clinical practice and beyond using forums like this to make sure that people know what to expect and how that may or may not apply to them so that they can benefit from both the research, but then the clinical practice.
My practice focus is in integrative medicine. And Heather, you start talking about the basics in terms of approaches to perimenopause that seem so simple and yet are so powerful when we give them time and space. Things like stress management, sleep, hydration, smoking, if you're a smoker, building community. Talk a little bit about those basic strategies.
This almost one size fits all well-being advice, right? It's so easy to blow off because we're all sick of hearing about the same stuff. And if there's anything that we have challenges with, knowing that it would benefit us doesn't necessarily help us manage those challenges or get any better at it if we're not good at it, or be able to change things that necessarily will always be a challenge for us. So I think that it can be easy to be like, and especially in a capitalistic society, to be like, I'm going to buy stuff and then I'm going to get some medications and then that's going to do it. And, that's not to say that there aren't both things you could buy and medications that can often help with this. But if that basic stuff, if you're not nourishing yourself when it comes to eating and nutrition, and you're not getting enough rest, and everybody won't stop crawling up your back to leave you alone so you cannot be so stressed out all of the time. If you're isolated, I smoked for 35 years, so my heart goes out to everyone who has a hard time not smoking. And that's one of those things where we can only in this world do so well with our nutrition, especially depending on who we are and what our privilege is. If we have an addiction, we have an addiction. It's harder to get support, like really supported, not just paid lip service to actually working on those things, right? Because for us, for instance, to be under less stress, more people have to start taking care of themselves and asking less of us. For us to be well nourished, especially if we're marginalized, we actually need some equality and some equity when it comes to our food availability, right? I mean, all of these kinds of things in order for us to get more movement, if especially we have disabilities that mostly nobody's going to make that work for us at a gym or anything else. Like, we need actual support in doing those things, not just somebody doing the usual, which is telling us that it's good for us and we're just going to go do it. Yeah, I mean, and I think it's also one of those things where this is a time of life where so many more things are often being asked of you that it seems like a real conflict to figure out how this could also be the time that you center yourself better, right? And take care of yourself better. How do you do that when more and more things keep going wrong with everybody else and your responsibility in them is bigger? And the way that everybody gets there is going to be a different way. But I think the big message to kind of walk around with is, at this point of life, it's almost like, well, if not now, when? Like, I mean, time is running out.
Not getting any younger. Right. No, it's a really good point. It's a very interesting time period, though, that I think historically has been really portrayed as this time of pulling back and sort of shriveling up, no longer fertile. We had a great conversation with Kirsten Miller, who wrote The Change, about changing the narrative around menopause and the menopause transition, that women actually, in her fiction, get these superpowers. And I want to talk to you a little bit about that in terms of sex. Obviously, we can't talk to the founder of Scarleteen and not talk about sex in the episode, but you obviously talk about it in your book as well. But you make some comments about how important the sexual experience is to embrace that it's an individual experience, that your body is changing, but that doesn't necessarily mean it's changing for the worse. You can often be more in touch with who you are, more empowered, more wise from your prior experiences. Talk a little bit about sex at this age.
Sure. I mean, I think a lot of what happens where people kind of say, oh no, this thing doesn't work anymore, is more times than not, the biggest hurdles around now are if people are still trying to stick to and make their bodies stick to this super limited heteronormative script about sex that probably for most people was never all that great to begin with, but you could do it, right? Like you could physically do it in a way that with menopause and post-menopause, some of this stuff you can't. Your body's just not going to have it anymore. It's so different, right? When we're queer and we're gender expansive, because we've always known that those scripts, most of us, don't work for us. So it's kind of like we're already in the habit of being a little bit better about adapting because we can exempt ourselves more from those scripts, not completely, alas and alas, if only. A lot of it is realizing that that never really worked, right? And again, now you're hitting a wall where it's just not going to at all. And it's almost like you're forced to make a kind of change that probably you would have been benefiting from all along, and I think one way of thinking about that is that for some people that really just have not felt able to give themselves permission to that, there's something that if your body just won't let you anymore, there's kind of a built-in permission. Maybe you couldn't give it to you, but now it's just what has to happen, which especially also for people that might have had a harder time talking to partners about changes like that. Sometimes it can be a little easier for that person, rather than saying, I just don't like this, to be like, my body just won't do this anymore. We'd ideally want the person in a relationship with anybody to be able to be more honest, but everybody's circumstances are different. But, I think it's another one of these things, and it's really interlinked with self-care, about learning how to center yourself if you haven't already. All of these things that you learn to center yourself in sex, to center yourself when it comes to the kind of care that you need, are only going to benefit us more and more as we get older and older, just like they would have benefited us a lot when we were younger. When people really kind of push against it and try so hard to keep things the same when it's just not happening, the outcomes are so different with people that just lean in to learn to be adaptive around this with themselves, with their partners, in their relationships, all of these things. It gets a lot easier. And for some people, it's bigger than that. For some people, this is really, really liberating, these particular times, because they haven't had them before, or it's been a while.
I think that that's just so important and so exciting. And it kind of goes back to what we were talking about with how we talk about the definitions of menopause, that we link things often to these terms of normal or natural. I'm just keep thinking about many of my patients' faces when I talk to them about sexual functioning, especially at midlife, and say, hey, there is no normal. And what a relief it is to know that they don't have to meet some expectation. The next challenge may be then explaining that to their partner, who may think that there's this normal that they have to be meeting too. But having permission to live in your body, explore your body and express it, it feels good. I think one of the things Denise may be able to acknowledge this too, that we also, at least as a sexual medicine provider, want to make sure that women know that sex should not be painful. And so many patients come into our office that have been having painful sex and just say, I thought that was how it was supposed to be. And so as part of that too, that first of all, you shouldn't be having sex if it's painful. And if it is, there's things that we can do, at least from a medical perspective, oftentimes in combination with amazing physical therapists and sex therapists. Probably things, Heather, that you know a lot about and talk to patients about too, or women, people about, but just making sure those two things, there's no normal and it shouldn't be painful.
And that it's okay for it to be painful, or it's even supposed to be painful, is anybody who was raised with a vulva or vagina, it's somewhere in there to some level or another, depending on in what communities and cultures you were raised. And so once again, it's interesting to me starting to really work the whole age gap when it comes to sexuality. But for sure, if somebody walked into, didn't even walk into, already had a very formed idea when they started to have sex that pain was normal or even was something that was supposed to be happening, right? Like, or it's not really sex unless something hurts at given times. And then, yeah, you hear how they can be, younger people go through their life this way, thinking if it's intercourse, it's painful. Then people get in the middle and think, well, you're not supposed to have to need lube, which is so weird, which is like saying you're not supposed to need frosting on cake. It's like, well, who cares if you need it or not? It's frosting. Why not have them? And then again, it comes through now here, especially for somebody who this is how it's always been. How do they know then that this is actually, it's never was supposed to be like this? And there's always, whatever the cause, whether you fix it again with medicine or you fix it with consent or you fix it with getting more relaxed, there's always a fix for it.
You talked about lube in the frosting on the cake, the normalization of talking about products for sexual health. And then Dr. Kling and the Women's Health Center have really done a good job of making that available through the Mayo Clinic store as an example. Not that you can't buy it from many other sources, but sometimes people need permission to find these things in places that they feel comfortable shopping.
Yeah, I didn't know that. That's a really big deal. And it's the same thing of when, and I know that you must know this, Jewel, like so many doctors don't talk about sex, period. And that silence alone really speaks volumes. If a patient has to start these conversations on their own, that is a whole different thing than, again, somebody introducing the conversation, even in the office, being really just normalizing everything. And then, yeah, if you can leave your appointment and you can get what you need in the clinic store the same way that you would with a certain supplement or anything else, that's amazing. That's fantastic.
We have to talk about hormone therapy because, Heather, your book is such an amazing distillation of the science behind hormone therapy, which is not for everyone. There's no single answer for everyone, but is such an important topic that can be really difficult to navigate through. I know Jewel and I both feel that your presentation of the topic was spot on in terms of it should be considered, and then you need to think about the risks to benefits, and that there are a variety of ways to do it that make it safer or more effective. It must have taken you years to go through all that information.
Literally, I wrote this entire book pretty much inside a year, inside a very small room in a pandemic in perimenopause, which has its pros and its cons. Like there's some things that makes it harder. There probably were some things that made it a little bit easier, actually. It's really freaking complicated. It's very, very fraught. It's interesting, the conversations that people will have or want to have and concerns about hormonal medications. It's so weird to me that they're so different than everything else, right? Like if it was normalized for us to, with any medication we're offered, being like, well, I want to hear a conversation. What does it offer me? What do I risk? What are my other options? What are the different ways that I can take this? How long do I have to take it to know if it's working? How do I stop it if I don't like it? Like ideally, and the healthcare system, especially in the United States as it is right now, is how do you even make this happen? But we should be doing this with everything. So of course, if and when you get to the point where whether you're looking at hormonal medications for gender affirmation or you're looking at them for menopause separate from that, it should be the same thing. But I think a lot like you see, I don't know, with certain psychiatric medications and some other things, there are pressure and vaccines, for crying out loud, right? There are pressures from different sides to do it, don't do it. Then you have the history that people don't fully know. And it gets so tricky. I think for whatever reason too, culturally, people think of hormone therapy as necessarily not reversible, is that like it does things that once it does those things, you're forever stuck in whatever that is. Unlike that, like it's medication. You can be using it and then you can stop using it. And the things that happen when you're using it only happen when you're using it. again, it's one of those things where, especially with this, you get that political intersection of it having mostly been about women. And now it is also about trans people. And then it is about how this is, always worked when it came to misapplications of the FDA and everything like that. It's just so thorny that I think the hardest part was making sure that I wanted everyone to leave that chapter being like, here are a range of options. No one better or worse than the last, or required or not required. Like, it's just here for you. If you want it, you could try it. You could not try it. There's different ways to do it, because that's really the other big thing, is that I think that one of the most gendering things about the medical treatment of menopause is that hormone therapy has only almost ever been estrogen based. And a lot of that has been around presenting it as people having and keeping their femininity, right? And this like weird binary view of hormones and gendering hormones and everything else. But I think that's also another thing that, especially when you're talking to trans and queer populations, that's a factor in thinking about hormone therapy. If all that you've seen is this is to help you be or stay feminine, there's nothing in there being like, this has nothing to do with any of that. And maybe you don't want a lot of urinary tract infections, or maybe you want to sleep better. All of these barriers are built into this. It's really something else.
Well, and we use a ton of hormone therapy to help with all those symptoms we were talking about at the beginning. Certainly, hot flashes are disruptive. They can impede your professional life. They can impede your ability to sleep. They can be unpleasant. So that's just kind of the tip of the iceberg, right, Joel?
Absolutely. So many symptoms, and having access to options for treatment is important. I'm pausing because I'm just digesting the idea of how estrogen-based therapies are also part of this gendered binary and how they're presented. And it's so interesting. I mean, from a research perspective, we think about the 17-beta estradiol and how it influences all the receptors and all the different parts of the body. But that doesn't address that question for somebody that's coming in that maybe is excited about their menopause transition, means that they're not going to have to ascribe or continue to hit these societal norms of femininity. I love that idea, just making sure to have that conversation with patients about the difference between the goals of treatment. And really, I think what you're saying, Denise, is addressing those quality of life impacting symptoms. And I think in my maybe biased view as a women's health internist, what I see more often than not is people being told they shouldn't use hormone therapy, or they can't use hormone therapy for reasons that I don't understand, that aren't evidence-based. And so feel very strongly, I want to make sure everybody has access to that, because hot flashes, it's not just an annoying symptom that you have. The symptoms, as you lay out in your book so beautifully, Heather, impact so much a part of your life, that having access to something to address those is so important. The other thing you said, Heather, that I think is so important, and I hope listeners also hear too, is this higher threshold for talking about the risks and the benefits for hormone therapy than we do with any other medication in medicine. As you said nicely, Heather, probably influenced by gender stereotypes or sexism or all these different things that probably fuel that discussion. Our research studies might as well. The Women's Health Initiative, which has influenced how we talk about hormone therapy. Oftentimes, breast cancer tends to be one of the fears that women have when they come in to talk about hormone therapy. And what's interesting is if you look at some really common medications we use as internists all the time, like calcium channel blockers, which is a blood pressure medication, or statins, which is a medication to lower your cholesterol, both of those have been shown to increase your risk of breast cancer. And some of the studies at a higher rate than hormone therapy. But I bet those conversations aren't being held when we're talking about starting statins or blood pressure medication. So it goes to show really the importance of having the discussions like we're having right now, and the importance of Heather's book is really to dispel some of those and give people the information they need to make those decisions.
I was presenting at a general medicine conference last week and talking about integrative medicine and menopause, but talked briefly about hormone therapy because it is the most effective for people who are candidates for it. And one of the audience questions was whether or not I had the patient sign a consent form before I prescribed hormone therapy. And I thought, do you sign consent forms for your blood pressure medications? No, you document that you had the conversation. It's shared decision. Everything has pros and cons, no matter what you decide to do. So you obviously have to have those conversations, but there's nothing special that requires a consent form for menopausal hormone therapy.
It really does, though, when you think back to it, that I'm like, right up starting with birth control pills. I'm like, the thread that goes through most use and known use, most well-recognized use of hormones, all just ticks all the little boxes of sexism and transphobia, and and misogyny, and it's all there. But of course, also within the Western medical system, it's baked in. So really, you don't see it on the face of it. People just, they learn it, as they come up. It's quite something. And it's interesting right now, having a foot in both worlds, to see what's happening with MHT and then what's happening with anti-trans initiatives around other kinds of hormone therapy.
That's a whole other topic. That is just enormous.
It is. We don't even have to ask ourselves the question of saying, well, if this were about cisgender men, would it be different? Because we know that it would, from seeing what happened with Viagra versus everything else. You bet your ass it would be different. It would be absolutely, completely different. None of this stuff would be issues.
Well, and your book ends with a fantastic appendix from Joanne Mason called Menopause for the Rest of Us, aka People Born with Testicular Systems. And to my knowledge, I don't think there are books that address that so directly as yours.
Including in trans references. That's the first time that we think it's been anywhere. And even doing it together was a little tricky because Joanne is considerably older than I am, right? Joanne is a trans woman, a couple of decades older than me. So we don't use the same nomenclature. And hers is no more or less valid than mine, and mine is no more or less valid than hers. So even kind of figuring out how to do that. And again, especially in this climate where getting people to be inclusive of menopause with those of us who are agender or who are transmasculine is hard enough. But then in anti-trans land, it's transgender women are kicked the most. So getting people to also realize that many trans women go through menopause several times just within decades is really tricky. I'm very glad. I was a little kind of worried out there, especially, when you have a guest writer in who's vulnerable, to be like, please, everybody, be cool. And so far, we've pretty much, I think, only heard people be really appreciative, which is great. It's a real gift that she gave to the end of the book there.
Well, you both are so amazing. The work that you do is so incredible, and the world needs more people who are willing to have honest conversations about these topics and these components of people's health. Heather, What Fresh Hell Is This is just such a phenomenal book. I hope so many of our listeners pick it up and read it through and maybe educate their friends and even their healthcare professionals from what they learned from it. I know we learned a lot from it.
Thanks so much. And thanks for having me here. It was really great to talk with both of you.
Thank you for joining us to talk books and health today on Read, Talk, Grow. To continue the conversation and send comments, visit the show notes or email us at readtalkgrow@mayo.edu. Read, Talk, Grow is a production of Mayo Clinic Press. Our producer is Lisa Speckhard-Pask, and our recording engineer is Rick Andreessen. The podcast is for informational purposes only and is not designed to replace a physician's medical assessment and judgment. Information presented is not intended as medical advice. Please contact a healthcare professional for medical assistance with specific questions pertaining to your own health if needed. Keep reading, everyone.